Welcome to The Gut Show. I'm your host, Erin Judge, registered dietitian and founder of Getelli. I'm also your fellow IBS warrior. Our goal on this side of the internet is to empower those with IBS and digestive disorders to understand their gut better, to have a healthier relationship with their bodies, and to make confident choices to improve their digestive health. During this season, you can expect a conversation around a hot topic related to gut health, digestion, and IBS. As a disclaimer, I am a dietitian, but I am not your dietitian. So everything covered in this episode is meant to be educational and is purely information that you can take back to your healthcare team in order to make the best decisions for you. If you're new here and something just doesn't feel right in your gut, if your symptoms have led you to this podcast, I invite you to start by taking the quiz, What's Your Poop Personality? Your personality type will unveil what your symptoms may mean, what may be causing them, and what you can do about them. This is a free quiz and you can take it today at getelli.com or find the direct link below in the show notes. While you're going to take the quiz, let's jump into today's episode. Now for a quick word from our sponsors with resources that might support you. Is a gluten-free diet just not cutting it, or maybe not even necessary when it comes to chronic symptoms like bloating, gas, and pain? Research actually shows that in those without celiac disease, it's actually the FODMAP, the carbohydrate fructan in wheat, not gluten, that causes symptoms most often. This means that you may not need a strict gluten-free diet to see symptom relief. And it means that if you are reacting to fructans, there may be more foods in your diet beyond wheat that are causing you symptoms. This includes foods like garlic and onion, and even some fruits and vegetables that can sneak their way into your diet and contribute to those chronic symptoms. So you can choose to limit these foods and reduce your overall fructan intake in order to avoid symptoms. You also have the option to break the fructan down using FODZYME, an enzyme blend that targets fructan, lactose, and GOS FODMAPs, and that will help you break these FODMAPs down to then prevent the symptoms. Learn more about FODZYME in the show notes, and you can use the code THEGUTSHOW for 20% off your first order. Did you know that you can now order your own gut health tests without waiting months for a doctor's appointment? Gemelli Biotech offers trusted, science-backed, at-home tests for conditions like SIBO, EMO, ISO, and post-infectious IBS. Their Trio-Smart breath test measures the three key gases, hydrogen, methane, and hydrogen sulfide, to detect different forms of microbial overgrowth. As for those with IBS symptoms, IBS-Smart is a simple blood test that can confirm post-infectious IBS with clinical accuracy. Validated by the leaders in gut health, these are tests that you can trust and tests that you can take comfortably from your home. So go to getgutanswers.com to find out which tests are right for you and use the code ErinJudge25, all one word, ErinJudge25, to save $25 on your order. And now let's get back to the show.
Welcome back to The Gut Show. I am your host, Erin Judge, and we are here with a really special guest, Katie from Endo Girls blog, and we're going to get into a little bit more of who she is and why she's here. But today's episode is all about endometriosis. And if you are starting to maybe close out of the podcast because you're like, oh, I'm here for gut health stuff and I want to talk about IBS. I don't know what endometriosis is, or that doesn't seem like it's applicable. I encourage you to stay because we're going to talk about why this is so applicable to our community and even learning more about some of the kind of common conditions that can be masked as IBS or overlap with IBS in different populations. It's really important because it helps with us, again, lifting up other parts of our community, but also possibly finding out answers for ourselves. So I hope that this episode is encouraging. It is eye-opening for you, no matter how you're tuning in. And if it's something that's deeply connected to you, you're definitely going to love this. And we can't wait to connect and engage with you after the episode. So thank you for being here. And Katie, thank you for being here as our guest.
Thank you.
Yeah, so excited. So before we get into endometriosis itself, I would love to hear more about your background. So who are you coming in? And I mentioned the Endo Girls blog. Give us a brief rundown of what the blog is and kind of how it started.
Perfect. Well, thank you. I am super happy to be here with you. So I'm Katie. I'm a board certified patient advocate. But before I got there, I went to school for biochemistry. So I got my BS in biochemistry after a long convoluted health journey that made it difficult to actually get through college. So eventually I was able to get that completed. And then after school, I had to continue pursuing a lot of my health, what's the word I'm trying to think of? Like complexities. And unfortunately, that took me into requiring a pretty significant surgery right after I graduated. So I wasn't really able to like pursue my career dreams right off the bat, which ultimately led into patient advocacy. My grandfather got diagnosed with cancer shortly after that, and I started seeing a lot of fractured components in the healthcare system. So somebody that had helped me significantly through my journey happened to be a board certified patient advocate, and I got interested in, what is that? And so I pursued that, and that led me into starting this Endo Girls blog, which now sounds kind of, I don't know, girly, young, childish, but it's just the identity of it now. So I haven't really gone about changing it. But another girl that, I had met through social media and went to the same surgeon as myself, her and I decided to start this blog online, if for no other reason, just it was cathartic for us to share our stories. And then it just turned into something completely, you know, mind boggling almost on social media where we just started to communicate and generate a community of other individuals that also had endometriosis, of course, was the issue that we were ultimately dealing with that we didn't know we had until much later. And it turned into me really being able to utilize my scientific background to break down a lot of the complexities of the disease and just try to provide a non-biased place of information, right? So social media is so full of sensationalism. So that's ultimately the goal, was to make a place where someone could come newly diagnosed or curious, having symptoms that might align with, what goes along with endometriosis, and a place where they could find accurate information. And then that turned into a referral database almost, where, reaching out to other healthcare providers that could help these patients as well. So I am still a chemist. I do chemistry work in the industrial sector. So I work in the power generation field, primarily at new power plants get built, and I do a lot of the chemistry at those power plants, a lot of water chemistry. So that is still my love, and I still do that. But I also am a board certified patient advocate, and I'm pretty active within that field.
That's amazing. Busy. It's a lot of things, but I know so incredibly rewarding. And we'll talk a little bit more about that. But now I want to take a step back and set the stage of endometriosis, because I think it's becoming more commonly understood as a condition where now I think even the name of it, people understand or recognize it a little bit. But I do think there's still some misconceptions about what it is. How do you like to describe endometriosis?
There's so many, yeah, like you said, there's not really a standardized definition of what endometriosis is. Primarily probably because there's so much about the disease we don't understand. So a lot of individuals, I like to just start it out as a whole body inflammatory disease, characterized by lesions, or however else somebody wants to put that. Characterized can be kind of like a technical term. So primarily it shows up as lesions internally, most commonly within the pelvis. It can be super painful. It can show no symptoms of pain, but cause other issues that I'm sure we'll get into, especially those bowel symptoms a lot of individuals experience. So that's kind of how I like to explain it, to keep it as easy as possible, because we used to call it, it was a women's gynecological issue. But because of that, everyone just thought it was like a painful period. And the more we learn about endometriosis, the more we learn that that's not simply what it is. And it is a whole body inflammatory disease, primarily characterized by lesions, but those lesions change over time, turn into scar tissue, and it can cause prolonged issues due to that. And it can be anywhere in the body, primarily, of course, in the pelvis, but anywhere throughout the abdominal cavity. And then, of course, we hear the wild stories of it in the brain, the bone, muscles. So it's pretty bizarre.
Yeah, yeah, it is something that's so interesting. And you mentioned, the need for accurate information for patients. And one of the biggest reasons why that's the case is that there's not a lot of science that has been done and understanding, like even how you mentioned, like it's hard to even characterize the lesions. How do they migrate to different places, and how do they form, when do you treat them to prevent certain things? That there's so much that's not understood or known about it, especially compared to other inflammatory conditions. In the GI space we look at IBD, and even that's still fairly mysterious, but there's a lot being done to understand it. There's a lot being done to categorize it, to know how to treat it. And I feel like with endometriosis, even though we've had some advancements in like women's health research, there's still a lot that's missing and very much misunderstood, which opens the door to a lot of opinions on what you should do, based on lots of little bits of data versus like really solid evidence, right?
Absolutely. And that
Yeah.
is one of the most important roles, I would say, of a patient advocate, is to make sure that the patient is aware of all of these different options and they're not feeling
Mhm.
forced into one way or another because of some, inherent bias.
Yeah, absolutely. So you kind of talked a little bit about the lesion. I do want to get into some of the symptoms because I think that that's important, because I'm sure that's part of your story too, of like what, those first warning signs. What are some of the symptoms that most patients experience? And then even some of your story of, what were some of the signs that looking back, you're like, oh, well, that was obvious now with what I know, but I had no idea at the time.
So I think the most common, or at least most commonly seen symptom would be menstrual pain, right? So, and that could be leading like right before your period, it could be during your period. Now we know it's anytime during the cycle, but traditionally that was the complaint that someone would come into the doctor's office with, and they would be like, oh, maybe it's endometriosis. If you're lucky, they would look into that. That's the primary symptom that gets people in the door. I would say, though, that the other symptoms that are the most experienced would be bloating, because they call that endo belly. So it's like this intense bloat that just comes out of nowhere, right? As you're familiar with, certain foods can do the same thing, but with endo, it's just like it's this inflammatory response, and you get this incredible bloating. But then also, another super common symptom is going to be gastrointestinal distress of some kind, right? So either that's pain with defecation, whether it's pain before when it's moving through, especially that descending colon area, and we can talk about that, but that is a really common place for endometriosis to create adhesions. And so there's a lot of pain right before those bowel movements or as it's preparing. Another common symptom is like low back pain. And I know that's like a very unspecific symptom that can happen for so many things. But when we start to think about it with endometriosis, there's so much inflammation in that part of the body, whether it's from, the bowel issue, whether it's from the lesions themselves, the scar tissue, it just can generate this intense ache that can shoot, nerve pain down your leg. So another, and then another symptom that most patients almost eventually discover they have, or some kind of like bladder urinary issue, whether that be pain or like these recurrent UTIs.
Yeah, and if people listening are not quite sure like why this might be the case, like I encourage you to look up like female anatomy, pelvic cavity.
Yeah,
Just
yeah.
look it up, and it's important to understand like what all is inside of our bellies basically.
Yes.
There's a lot of organs squished into one space, and they're all connected to each other in some way, even though they're meant to be separated. And when we're talking about adhesions or how these lesions may, they're primarily on like the uterus or the outside of the uterus. That's the kind of, I guess, cookie cutter version of endometriosis. But that space, things can go easily to the bowels. It can go easily to the bladder. It can go easily to even the abdominal wall. Like there's a lot of spaces where lesions can either grow to where they're touching other spaces or can be in other spaces. And if those lesions are active, they produce pain. And then if they become adhesions, if you Google adhesions, if you've ever, gotten cut on a muscle or had an injury that cut through any muscle in your body, and that scar developed from that, you can see where it kind of squishes and pulls from the rest of your skin. That's an adhesion, and that happens in the internal like organs, which are all smooth muscle. And if there is something pulling at that muscle, that's going to cause pain in other areas. It's going to cause imbalances. It's going to cause slow motility or altered motility, some cases blockages. There can be some pretty significant reactions to that. And, we'll talk a little bit about the GI overlap in a minute, but when we start thinking about like that progression of endometriosis, right? And primarily, and I'd say those with like female anatomy, but those who have obviously a uterus and are typically menstruating. So can pop up as early menstruation and can, I guess, come on, I guess the first stage of endometriosis, typically prior to menopause, right? So in that menstruation life cycle, do you know if there are any stats on like the age range that's the most common? I know the problem is that diagnosis happens way later, but do you have any stats on that?
No, I don't have any, just because there are so many variables, right?
Yeah.
Unfortunately, and diagnosing is difficult, right? We're just now getting better technology where we can do some less invasive, but primarily endometriosis is still a disease that is similar in cancer in that definitive diagnosis really does depend on some kind of histology. So basically taking a biopsy, for anyone who may not know, taking a biopsy and looking under a microscope, but that's not without flaws either, right? It depends on how good the specimen is. It depends on a lot of things. So some doctors will go ahead and diagnose if they see what are called endometriomas, what are like big, they're called like blood-filled cysts, but it's not real blood. It's like a real thick, they call them chocolate cysts because it's real thick substance inside. You can see those on an ultrasound. Those are indicative of deeply infiltrating endometriosis. So a lot of the times we'll just say, if you have that, then we're just going to go ahead and diagnose you with endometriosis. They do behave very differently than the lesions. That's a whole other really intense, like really deep discussion that is had within the community, but it's really hard. But we do know, and even the general statistic on it, which has always traditionally been like 1 in 10, Australia will say like 1 in 9, of girls and women between the age of, they usually say like, oh, what is the age? Maybe they always just say like childbearing age, which is also
Mm-hmm.
vague. But I will say, just from my own personal experience, the hundreds of individuals that I've worked with, and I work very closely, like communicating with a lot of top surgeons for endometriosis to talk about what they see in practice. We do
Mm-hmm.
see quite a bit of endometriosis in individuals before they have started their first period. And we're thinking it's
Interesting.
because it's not the menstruation itself that has to do with the endometriosis. There's, one of the prominent theories of endometriosis is that we're born with it already, and it's the change leading up to puberty, that kind of prepubescent period, where you start to grow breasts, but you haven't started your period. That increase in estrogen is kind of triggering those lesions, because most of those lesions will have estrogen receptors. And so as that estrogen increases, it starts to like activate in a way those lesions, and it can start inducing pain. So a lot of young individuals with endometriosis will experience gastrointestinal pain first prior to menstrual pain. And that was my story as well. I was missing school by third grade because of my bowel symptoms. And then by fifth grade, I had started my period. So it was definitely that natural progression leading up to it.
Yeah, that's really helpful to understand. And that kind of makes sense with the whole like menopause thing too, is that like as estrogen maybe decreases or shifts a bit and hormones are shifting, we may not see quite as severe pain that fluctuates as hormones fluctuate, but there still may be this like adhesions present, which I know I've seen in some older individuals who maybe were told they had endometriosis back in the day when there was not a lot of treatment done, or, there were just these kind of misconceptions even then, but then now they're older and they have pretty significant constipation and pelvic floor dysfunction and, all these sort of non-specific even symptoms with a long history of life where they're maybe had children and, all these other pieces, but that could possibly be part of it. And then they're just not dealing with the fluctuations, which leads to some of the mystery of, well, is it this? Is it something else? Because there's so many conditions that can lead to the same symptoms. that leave you hitting a wall. And one symptom I do want to clarify, this is what I believe to be true, but I don't know if I have any statistics backing this up either. But something that kind of differentiates endometriosis, which I think makes it more complex when we look at GI overlap, is that with menstrual cycles, your regularity is not necessarily as hallmark of a symptom. Correct? Is that correct compared to like a PCOS, where we have irregular menstrual cycles, where the cycle length may be all over the place? And we see infertility in PCOS for that reason, right? Because we don't have proper ovulation and there's some things going on there. With endometriosis, cycles are typically fairly regular. Irregularity isn't necessarily as common, but severe pain is extremely common, which you don't know that you have severe pain unless you have someone to compare to. But if your cycle is normal length, it can lead to a little bit of that confusion, correct?
Right. There's a lot of confusion there also with the overlap with adenomyosis and heavy bleeding. So a
Yeah.
lot of individuals will think that heavy bleeding is a hallmark sign of endometriosis, but it's not. And I still see that cited in literature, which kind of drives me batty. But we have significant amount of research, at least on that, that there is not a correlation between a heavy period and endometriosis. But adenomyosis often coexists with endometriosis, and adenomyosis causes that significant heavy bleeding. So there's where that overlap comes into play.
Mm-hmm.
And adenomyosis causes that significant cramping pain. So whereas adenomyosis is it feels like the uterus is actually contracting, endometriosis type pain is more like stabbing, all throughout
Yeah.
the pelvis and the abdomen. It's like that sharp stabbing, aching, just doesn't end. Whereas, adenomyosis is going to be the actual feeling of like contraction. And so there's just like you were saying, there's a lot of overlap. And that makes statistics difficult with endometriosis, right? Because so much of it's convoluted. But for the most part, yeah, there's not going to be necessarily like any kind of irregularities. There's not going to be heavy bleeding. And of course, that makes it confusing. You're like, well, everything else with the menstrual cycle is normal. So the pain must be from something else.
Yeah, absolutely. And infertility is fairly common in endometriosis. So we're going to get to the fertility conversation later. I think that's a big, important discussion with like treatment options and things like that. But we're talking about people early in childbearing age and even early 20s. Like, you don't know that you're dealing with infertility unless you're trying, right? And so
Right.
if that is possibly and that's not always a symptom everyone has either, which is confusing, but can be common, but not due to irregular cycles necessarily. So kind of it just makes it a little confusing. And thankfully there is a little bit of data, like correlation data, looking at like IBS and endometriosis, which makes sense because all of the symptoms you talked about, like pain is a hallmark symptom of IBS, right? To be diagnosed with IBS, you have to have pain and a change in bowel habits in some way, and the pain's related to that in some way. So very specific in the GI space, but very non-specific when we look at other conditions and other things that can be going on. And as you mentioned, it is very common for people who have endometriosis to have some sort of GI manifestation. I see constipation more frequently. I think we see that in the literature as well, but that is probably just looking for it kind of correlation data. Like that's what we know we're looking for. So we kind of pinpoint that versus looking at diarrhea specifically. But we see the bloating, we see pain in the pelvic area. We see pain that does seem specific to bowel movements. We see constipation. And because we don't have, I feel like I grew up at a time, I'm 33 now, or no, I'm 32. I'm somewhere in my early 30s.
I forgot after
I'm at the age where I'm forgetting my age. But it's not that long ago, right? I grew up in the time of like technology developing and everything, but menstrual cycle education was not very common where I grew up and was not helpful. I didn't know the difference between like what is a normal flow? What is a normal cycle length? What is a normal amount of pain? Should I just push through it? Should I not? Should I be at home? Do I need medication? Do I not? Like there was, some information provided, but what was considered quote unquote normal to understand what would be abnormal, like wasn't available to my generation of people and then where I grew up. And I feel like even now we're seeing a better like amount of education, I think, given to young females who are menstruating and entering that stage of life, but it's still not quite, I think, where it needs to be, where I feel like we've normalized some things that maybe aren't normal, while also still have that, like, we're still tough and you can push through it kind of mentality, which leads people to feel either embarrassed that they can't, or like, well, maybe I should, and they're just suffering in extreme pain that they shouldn't be suffering through, right? So there's this confusing piece of menstrual cycles and pain. And what happens is that a lot of young women don't actually bring up gynecological concerns in the gynecological space, right? It's like that pathway has not always been open. A lot of young individuals are also not getting access to gynecological care and a gynecologist. We don't necessarily get access as soon as you start menstruating. We should, but we don't, right? It's not always the direct pathway. However, dealing with severe constipation and bloating, especially, or having diarrhea and like bowel habit, that is something that gets brought up to the primary care provider. That is something that gets you a referral sometimes a lot quicker. So people tend to see a GI doctor a lot quicker. So some of our correlation data we have is still very dirty, if you will, because we don't, maybe there wasn't a diagnosis of this before this. Is it really this? Is it that? But some of the data that does exist is that those with endometriosis are about 2 to 3 times more likely to develop IBS. And then looking at that prevalence is about that 20 to 30%. I believe I saw some stats at some point. I couldn't find the stat again. This, I think it was in like a educational, like another dietitian shared it, but possibly around 50% of menstruating individuals with IBS-C could have endometriosis, which is a really high amount. That's also not surprising.
Yeah. I just pulled this. I was able to find, that's what I was.
Did you see that one?
I just pulled the stat. Yeah. 50, at least in this, one of the most comprehensive recent studies that was done, it was 51%. And then even individuals without even up to 80% will have constipation. That's just for constipation.
Oh, of those with endometriosis. Yeah. Which makes complete sense, right? And so getting an IBS diagnosis first, and like I mentioned, the pain is a hallmark symptom of IBS. So it begs the question of, well, was it ever IBS? Is it only endometriosis? Is it both? Because of the endometriosis, do we develop hypersensitivity where there's pain?
Yes.
I know there's some researchers now looking at even endometriosis and the impact of those lesions, whether it be the circulating estrogen or the inflammation itself, causing actual changes in the gut that we see in IBS, like impaired permeability, that leaky gut, or changes in the gut microbiome. Healthy microbes don't tend to thrive in a state of inflammation. So it's very fascinating to see that overlap and to see, you know, with even the IBS pool, about what 75%, I think it's still our stat, are women compared to men. And there's the question of like, well, why do more women have IBS than more men? And you throw this into the mix. So very interesting to see that overlap. And yeah, I found it really interesting. And I remember whenever I started working in like the IBS space, it took me a while to really start digging into endometriosis, which I think is still so fascinating because this was like 6-7 years ago. And it wasn't talked about, especially in the GI space. I feel like today it's barely discussed. And I remember starting to look for it, and it has turned out about 50% of my patients with IBS-C that have some sort of menstrual history, you know, we're going in that direction to look at endometriosis. So interesting. But that leads me to the question, and I would love to hear from your perspective, especially in the advocacy space, trying to get a diagnosis and getting to that point. I can, as a provider, I look for red flags and all those things you mentioned, right? I have someone who's already dealing with constipation, bloating. Maybe we've tried some strategies. I always track menstrual cycles. So if someone's not already on like hormonal therapies and we have a cycle that we're looking at, when we see those significant shifts in symptoms, premenstruation, menstruation, ovulation, when those like nice little windows of relief are kind of sandwiched between those, doesn't seem to be related to food necessarily. And then these non-specific hip tightness and back pain and
Mhm.
all these other kind of components, like that's usually my flag of like, okay, we need to refer out, find an endometriosis specific like specialist that would do surgery if needed. That's going to be the first door that we try to go to, get GI on board. That's my path as a provider. But for patient, it's not always that simple. So I'd love for you to talk about that, even maybe your own story of that, but also with patients. What do you typically look for to try to get a diagnosis, or kind of talk through that path?
Now for a quick word from our sponsors with resources that might support you. Are you struggling with bloating, constipation, or diarrhea, and you're still waiting to see your doctor? Take control and get answers with Gemelli Biotech's at-home gut health tests. The Smart breath test is the only at-home test that is validated to look for all three gases that are associated with microbial overgrowth: hydrogen, methane, and hydrogen sulfide. That means it can detect SIBO, EMO, and ISO in one simple test. It ships right to your door, no appointment needed. You take it and you send it back, then you get answers. If your IBS symptoms started after a stomach bug or food poisoning, it could be post-infectious IBS. The IBS-Smart blood test is a quick at-home test to help identify it. Fun fact, 1 in 9 people who get food poisoning will end up with post-infectious IBS, and most don't even know they have it. With both of Gemelli Biotech's tests, you'll get clinically backed results in about a week, and you can take them straight to your provider. No waiting, no referrals, just answers. Find out which tests are right for you at getgutanswers.com and use the code AaronJudge25, all one word, AaronJudge25, to save $25 on your order. You can also find all these details in your show notes.
When it comes to irritable bowel syndrome with constipation, or IBS-C, there's no one-size-fits-all treatment. If you're not satisfied with your current IBS-C medication, it may be time to try something different. Ibsrela, tenapanor, is a prescription medicine used to treat adults with IBS-C. Ibsrela works differently to help relieve the constipation and abdominal symptoms of IBS-C and could be the right option for you. Ready to try something different for your IBS-C symptoms? Ask your doctor about Ibsrela. Do not give Ibsrela to children less than 6 years of age. You should not give Ibsrela to children 6 to less than 18 years. It may harm them. The most common side effect is diarrhea, sometimes severe, and your child could get severe dehydration. Stop taking Ibsrela and call your doctor if you develop severe diarrhea. Do not take Ibsrela if you have a bowel blockage. Tell your doctor if you are pregnant or breastfeeding and about the medicines you take. Other common side effects include swelling or a feeling of fullness or pressure in your abdomen, gas, or dizziness. Learn more at ibsrela.com/PI or call 1-844-IBSRELA and press option 4. As someone with IBS-C, I've struggled with symptoms related to food for the majority of my life, specifically FODMAPs. My personal triggers, beans, dairy products, garlic, and onion, would leave me feeling bloated and uncomfortable after meals, especially whenever I was eating out or traveling or living my life outside of my home, which meant I either had to just deal with the symptoms or eat bland, awful food and miss out on experiencing the social interactions and the joy of food. Finding FODZYME was a game changer for me. This is an enzyme blend that targets FODMAPs, specifically the GOS that's found in beans, fructan in the garlic, onion, wheat, and even different fruits and vegetables, as well as lactose in dairy products. I stash this in my wallet, my husband's wallet, every bag I own. I take it with me everywhere I go so that I can simply sprinkle it on my meals, eat with confidence, and feel my best after. If you want to try FODZYME for yourself, go to FODZYME.com and don't forget to use the code THEGUTSHOW, all one word, THEGUTSHOW, for 20% off your first order. And now let's get back to the show.
So just because everyone's symptoms are a little bit different, the pathway can be a little bit different. I will say a lot of people do end up going the gastro path first, right? They get an IBS diagnosis, but it's from like a primary care, and then they're just kind of left at that, right? Like no one's ever referred to a dietitian, I feel like, like it's never like pursued. So like for my own story, I would go to the emergency room. One of the first times I went to the emergency room, I lost consciousness and I was told that it was me. It was just a vagal response from a painful bowel movement. And they were just like, that's it. So you need to take Miralax. That was their answer over and over again. And, I would just, okay, I guess that's it. I was like, my diet is great. I was, I really focused on that. My dad, I always joke, my dad's like real hippy dippy. And he always had me doing, all sorts of stuff from a young age to try to be as healthy as possible, because bless his heart, he always wanted me to feel better. I mean, he put like a whole home water filtration system in when I first started experiencing gastro symptoms as a child, just because he was like, maybe it's in the water, And so I was like always had done that, wellness route, and things just still weren't working. And so it wasn't diet. We just couldn't figure it out. I was fit, but I was just still being told Miralax. So I think, and one of the movements within the endometriosis community right now is trying to educate primary care physicians. That first line of who the patient's going to be seeing is to look for those type of symptoms. Okay, they might have IBS, but then asking the other questions, right? Because patients don't necessarily, and I've noticed this with people as well, they don't necessarily know that they're experiencing certain symptoms that could be endometriosis. So you have to poke and prod, which a good doctor should be doing, right? Asking those other questions that are more specific. Do you have, pretty bad cramps with your period? Even if they don't, or the stabbing pain, even if they don't, but you can, asking, do you have moments where just it feels like you're sporadically bloating to the point where you can't button your pants? And where is that maybe in your cycle? Or so many are on birth control that can make it difficult. But, do your stools change often? Do you experience the constipation? Just as more targeted questions are really helpful for patients. But also what's important for the patient to do is track. And so if someone's trying to go to the primary care physician and they're not getting answers and they feel like they're not getting help, I always say, well, let's track your symptoms very specifically, like when certain things are happening. Are they happening after you eat? What are you eating? Whatever. A lot of patients patients with endo will say, I drink a glass of water and I'm bloated, to the point where it's painful, not just a little bit like pre-period bloat. It is like you cannot put your pants on type of bloat. And it's stabbing pain. So I think, I'm really big on having a primary care physician, because they can, if they're a good one, they'll look at you as a whole. Because when we go once we get to a gynecologist, especially if we get to somebody who is focused on endometriosis, that is their focus, right? And even though they may know endometriosis is a whole body disease, they're still kind of outside of their realm, right? They're going to focus on where it is, especially if they're doing surgery. They do laparoscopic surgery. So that's within that abdominal pelvic cavity. And endometriosis is often found on or near the bowel. So it's really important to have a lot of surgeons will have a colorectal surgeon partner with them during the surgery. But it's getting that diagnosis. It depends on where you are in the world. For instance, some countries, surgery is really gate kept. It's not something that's going to be accessible. So there's more of a reliance on maybe imaging. But fortunately, now there are certain facilities that can do really detailed MRIs. There's a protocol specifically for it where, you're either ingesting something or doing some kind of enema prior, where they can maybe see endometriosis a little bit better. So for the diagnosis part, it's so hard to say, because not everyone's going to have access to all these different types of providers. So typically, the unfortunate thing is a lot of the time they'll go to a gynecologist, will just try to put them on birth control to manage the symptoms, which is a first line of treatment for endometriosis, love it or hate it. Sometimes a 16-year-old's not ready for surgery, and that's really the only option they have. But I also make sure patients know that it's okay if you don't want to take birth control. But some may need birth control just to function until surgery. But fortunately, I guess all of this to say, I think that primary care physician is a great place to start, and to always keep them in the loop. But primary care really does need to start referring. We need a better referral base for surgeons that are focused on endometriosis. It's really important for patients to know that an OBGYN is not necessarily somebody who should be diagnosing endometriosis. The general rule of thumb is if they're still delivering babies, they don't really have the time to be focused on an endometriosis patient. We're too time consuming. It's just not possible to really truly understand the disease and become proficient enough in the surgery to know how to identify it and be delivering babies. So, if possible, it's try to find a gynecologist that's no longer practicing obstetrics. Was any of that helpful?
That is really helpful. No, I think it's good to talk through. And I think the part of it that I think is the most helpful is it's complicated because there's not always one direct path. And, usually you do see imaging first, but as you mentioned, sometimes imaging shows it, sometimes imaging doesn't, and imaging is not conclusive. And then sometimes you'll have laparoscopy, laparoscopy, but the other word, laparoscopic surgery. Laparoscopic. It's like I'm saying something wrong.
We got
laparoscopic. You call it a lap if you want, but you may have the surgery, and that is investigative and possibly treatment oriented. But that can go a bunch of different directions, and may be helpful, maybe not helpful in the long run, right? And then there are new treatments that keep popping up. There's hormonal modifications that may happen where you try to decrease circulating estrogen to help reduce the lesions, kind of feeding on that, I guess. But that is meant to help maybe slow progression or at least slow symptoms, but not foolproof. And there's just a lot of possible, there's even hysterectomy, right? Some people go that direction and go full on surgery. And so there's a lot of different directions people may take. And this is expensive. Not all of this is fully covered. Often not very well covered, as I found. And then not all doctors will do all of those options, and patients may have a say, but sometimes they don't get a say as much as they want. And it's complicated.
It is. And it's compounded by the fact that so few surgeons actually know what to look for. So a lot of patients may go in for surgery and they say, well, we didn't find any endometriosis. Well, they didn't do a biopsy. Maybe they didn't know where to look. They just kind of do like a quick peek because they're just using a very focused camera, right? And so they're just seeing a small area. Very, very few are going to take the time to fully investigate. And that's just because a lot of the time they're busy, right? And insurance dictates so much of their time and what they can do. So you get a lot of patients that have an inconclusive surgery. That's unhelpful. And then you get some that are like, well, it looked like a mess in there. You should just have a hysterectomy. But that doesn't treat the disease, right? Because we always joke about that. It's like, why are you removing an organ that may not even be impacted by the disease to treat the disease, right? Because if you've got bowel endometriosis, you can remove the uterus and it's not going to make a difference. But it can, I opted for a hysterectomy. It was a great decision for me, just because I was done. I didn't want to have another period. They were traumatic. So there's a lot of valid reasons for someone with endometriosis to have a hysterectomy. But like you're saying, a lot of it's cost prohibitive.
Absolutely. And not always even available. It's not accessible for a lot of people, even outside of cost. And it doesn't always matter what country you're in. I've had clients from Canada who don't have access to the right providers, or the time, like the wait time is way too long. And when you're looking at trying to get ideally treatment and also get an answer for really significant symptoms you're dealing with today, 6 months to a year wait to try to get in to even consult with someone who's going to be able to do a surgery for you, that's way too long. And so I've had people travel, to different countries to try to get it and meet with the right providers. And as you mentioned, that's not always created equal. Just like on the GI side, like your provider does make a huge difference. And you can sort of vet them out by looking at their specialties and looking at what they primarily practice and, what other patients have received in terms of care. But that doesn't necessarily mean for you that it's going to be the exact same way. And so I would say this space for patients is one of the most complicated and emotional, I guess. Like there's a roller coaster involved in trying to navigate it. And there's also the fertility part. So I'd love to talk about that if you're open to talking about that, because this is a conversation I have with a lot of patients in their early 20s. Whenever we're trying to navigate, okay, what's going on? They've been impacted long enough by the symptoms that they're experiencing. They're trying to consider their treatment options. Often birth control is an option, right, to help with symptoms. And something that a lot of patients are told is, well, if you decide that you want to have a baby, we can revisit this conversation. Like that is really common, right? And then patients who aren't sure what they want to do, like they feel very left out of that conversation because they're like, well, how do I even navigate that? Like I'm suffering day to day, right? So how do I even think about that conversation? Or maybe I'm not ready for that. or people are ready for that. And I don't feel like sometimes they're always told the how infertility may affect some patients and how treatment may or may not always improve those outcomes. And so when they are ready, now that conversation is really complicated. Or some patients don't want that at all. And they're not offered options that, like a hysterectomy, right, that could help them that they would prefer because they're too young to make that decision, right? It's really confusing. And then the people who obviously want that and then can't because of this, like, we see this on TV a lot. We've seen this on The Bachelor, I think last season. And, there's a lot of reality shows now where women with endometriosis are on these shows and they talk about how, well, there's a clock, right? There's high risk involved and I need to make this decision more quickly. And I feel like there's just a lot of conversation about it that's really complicated currently. So I don't know if you if you want to share anything there, like with patients that you work alongside of that side of it that I think can be sort of there's a lot of misconceptions around it, but also it's just very complex even beyond the symptoms themselves.
Absolutely. And I think just part of this work, I work with a lot of individuals who go through this exact thing because I am somebody they can talk to about a hysterectomy because I've been through it. And even one of my ovaries removed. I had my cervix was removed later, which is it's a trachelectomy, which actually requires removal of part of the upper part of the vagina. So a lot has happened. And so it's an important discussion to have with patients regarding quality of life versus maybe what they want versus societal expectations. It gets very nitty gritty sometimes. And I always tell them as well, like, I'm not a therapist, I'm not a licensed counselor. Sometimes that's important to bring into this discussion. So as their advocate, I might suggest that as well. But I have more often than not worked with individuals who are like, well, I'm getting to the point now where maybe, my partner and I are becoming more serious. We're just starting to discuss this, but I don't actually know if I want this. But my doctor's telling me that I need to get pregnant sooner rather than later. And so what I basically do is I'm like, let's just take a step back and let's think about what you want. If endometriosis wasn't there, what would you want? Let's take it off the table. And then we start to go through the non-biased literature. What does the science say that we can see about it? Yes, infertility is common, but it's not 100% guaranteed that's going to be your case just because you have endometriosis. And it's really ethically wrong for doctors to be saying pregnancy is a treatment or pushing pregnancy as something that should be done just because of a disease. So for some, that it's important for them to know that it could be a possibility. So if they're ready for it and they want to go ahead, then go for it. But I was in that category where I was denied care because I wasn't ready and I didn't want to. But I had an amazing primary care physician who, this is before no one ever talked about endometriosis. It was like not a thing. He's the one that diagnosed me. And he told me back then, he's like, the only way to get a diagnosis is surgery, but they're not going to do surgery because you're young and you're not wanting to get pregnant. He's like, so if you go to the go to the gynecologist and tell him you want to get pregnant, but you're worried because you got painful periods. Sure enough, they operated. And I mean, it's messed up because I lied, but he told me, he's like, this is what you got to do. And he was right. And it worked. But what was gross was that right after she told me to get pregnant and I was, not even in a stable relationship. She didn't even ask, none of those things. And it was just not even a discussion. It was just, okay, well, now's your time to get pregnant. Shoot me out the door. And so having that experience, I really try to empathize with others that may be going through something similar. And it's also important to note that, the only treatment option that they're given is birth control. Well, obviously you can't take birth control and if you do want to get pregnant anytime soon. And it may be controversial for some, but it is true just from what I've seen with patients that are on long-term hormone suppression. It seems to be more difficult for them to get pregnant. Not always, and maybe it is just an endometriosis thing, but I see it. The worst of all is if the patient doesn't respond to birth control, they'll push a harder medication that actually shuts down the ovaries. So it puts them into chemical menopause. The thing with that is that it's not effective. There is no data to show that it is more effective than birth control taken continuously. And I have all of the data on this. And we actually don't have long-term data that shows whether or not ovaries ever fully recover. So the only data available is like 6 months, maybe 12 months, showing that some bone density returns and that maybe some have a menstrual cycle again, but we don't have any solid data showing that, okay, your body has recovered, your ovaries are functioning fully again. So that's another thing that patients aren't told. They're just told when they take these drugs, everything will go back to normal because they're just regurgitating maybe what's on what they're being told by a rep or what's just kind of like in the echo chamber. But I always encourage patients to look at the actual FDA drug approval because it's there, right? So or talk to a pharmacist. They're often a lot more knowledgeable at least. So it's not saying that the doctor is necessarily doing anything wrong. They're just not fully informing the patient. And when it comes to infertility, that's a significant issue. But also with endometriosis, a big part of the infertility part is the inflammatory nature of the disease itself. So we know like pelvic inflammatory disease, certain STIs really impact fertility, miscarriage rates, and the same goes for endometriosis. So a lot of the time, a patient will go in and have a thorough surgery where the lesions, at least everything that the surgeon can find, is surgically removed, not just not just burnt on the surface, which a lot of OBGYNs do, but cut out. You can reduce that inflammatory environment where then pregnancy tends to be a lot more prevalent after that. And it's creating an environment that's more, I guess, it's less of the immune system trying to fight something off, and it's a better environment for becoming pregnant. And so there's actually a whole field of this. I don't know if you're familiar with it, called NAPRO, natural reproduction surgeries, where they go in and they're restoring anatomy, and they're going in and trying to remove any disease that's found within there, even scar tissue. So it's just a very delicate environment. Just like our gut microbiome is delicate, the vaginal microbiome is very delicate. We're just delicate internally. The body is very good at surviving and protecting itself. And so I always tell people, I'm like, it's kind of in this state where it's like, if it says it's not capable of doing something, it's probably not going to. So a lot of patients have significant success with having a proper surgery. So I tell patients, let's take a step back. If endo wasn't on the table, what is something that you would like for your life? Okay, here are your options, because that's my job as a patient advocate. These are your options. And if you would like to, maybe you can go ahead and consult with one of these surgeons, and we can look at statistics and we can look at data and other patients who've maybe had these surgeries later on that have helped become pregnant. Another piece of this puzzle that I really have to address is the fact that more and more surgeons are starting to discuss the impact of in vitro fertilization on endometriosis. So I've spoken with numerous surgeons who have had patients that they've resected all the disease themselves, or they've been to a surgeon that they trust and they've seen either video footage of the surgery and they've seen images after the surgery. Maybe the patient's had a follow-up surgery where no endometriosis was found. So they've got these patients who have had thorough surgeries, no endometriosis found on a second surgery that maybe was done for something else. They undergo IVF and then they're blown back up with endo. So there's obviously something happening there. So maybe they're excising and cutting out all of the endometriosis that we don't really like to say active, but at least that could be causing some kind of issue. But who knows what's below the surface somewhere that we're not seeing. And while those lesions or little seedlings, whatever you want to call them, may have never caused an issue again, something within the IVF treatment is like fueling it. It's like gasoline. And so now that more and more surgeons are starting to talk about that, I think that's something important for patients to know.
Yeah, that's really helpful, because you do see that often as like for people who maybe don't find out that they have endometriosis until they are trying to get pregnant. They may have already undergone IVF, or it is common where they do their treatment and then they go right into IVF. Like that is something you see fairly often. And so it's helpful to see, okay, well, could that be backfiring? And is there more time needed? Or like, patients, experiences might be able to look a bit different. We've covered a lot of those like misconceptions, which I think are really helpful. And you kind of hit on this a little bit indirectly, but there's no cure, right? Like surgery, even it can be effective at improving the environment, improving symptoms, decreasing inflammation. I don't know if we call it remission. I don't know if they
It is, yeah, they call it remission.
Considered remission, yeah, where it's like you're not an active disease state necessarily, but you're not necessarily cured even with the right surgery, correct? Because there can always be
the
the possibility is always there, and you see it a lot. And I think something I'd like to hit on briefly as we wrap up is something you said towards the beginning as well, is that what we currently understand of this disease is that it's not always within your choice and your decision making or the things that you do that determine if you have it or not, but also how it progresses, correct? Like, I know we have some, from a diet perspective, we have very terrible correlation data looking at diet of like, ultra processed foods, red meats, the same things we see with like other inflammatory conditions and things of like, there's like an increased risk of possibly having endometriosis. And it's like, well, is that simply because it's already there? That's just life, because those are common things that people eat a lot of. Or is it true that like maybe there are some diet, just like with the gut, right? Maybe overall like composition of diet and your environment can impact the inflammatory response. If you already have endometriosis, could it be more significant and severe because of your diet or excess alcohol intake or drug use or whatever it may be? Possibly. But that data isn't even really that strong enough to even show like the small changes. Whereas online, we do see a lot of conversations about like, you should be super strict with your diet. You need to be gluten-free. You need to be blah, blah, blah. Obviously, like a Mediterranean diet, anti-inflammatory style diet probably is helpful, just like with the gut, but the guardrails on that are not as strict as what people may say that they are according to the data we have, right? Most of the data points to the mystery of it doesn't really seem to matter.
It doesn't. So you get a lot of like, you get a big echo chamber of people who a specific thing worked for them. And then you got coaches and you've got people doing all sorts of wacky tests. And I've worked with so many patients who spent thousands of dollars. And that saddens me because that could have gone elsewhere for them, but it's also part of the learning process. And I'm very passionate about that because like I said at the beginning, I did that journey, right? I worked with a naturopathic doctor. I did the whole wellness part of it, but the reality was maybe that worked for 5, 6, 7 years, but the disease did progress. And so ultimately ultimately it all still ended up how it ended up. But with endometriosis, and I've noticed this, we do know a little bit about the lesions. We know that not all lesions are identical. Some have different receptors. Some have progesterone, some have estrogen, some have a little bit of progesterone, some have none. So taking into consideration just how varied the disease is, I think that helps with understanding why there's not a one size fits all. And I think for each individual, it is trial and error with food. That's why I always suggest let's find you a dietitian who's going to work with your specific environment, your specific microenvironment, because this other diet may have worked for the 500 people in this Facebook group that swear by it. That doesn't mean it's going to work for you. And it doesn't mean you need to spend $5,000 to work with this coach when you can find an actual dietitian that can help you sort through what is actually working for you. So, and I did that, right? I did elimination diet. I have figured out what works for me. Even today, because another thing that I do want to hit on real quick when it comes to digestion with endometriosis is that the surgeries themselves can cause complications with your digestive tract. And sometimes they heal, sometimes they don't. And more patients we're seeing with endometriosis after surgery having C. diff. So that's a whole other part of it. So it's very individualized. I always tell patients to be very wary of all the diet stuff, right? It's so easy to sell something online. There are people call themselves like functional nutritionists. I'm like, that's not even an accredited thing, so like, again, we're looking at credentials and find somebody who's going to be very nuanced. There's no black and white and understands the fact that we are all unique individuals and endometriosis is not a one type disease that looks the same in everybody. The lesions have their own microenvironments like a cancer tumor does. So what your little endometriosis environment looks like is going to be different from somebody else's. So it's very important to take that personalized approach. I think diet can be super helpful with quality of life. Sure, it may not cure your disease, but sometimes the ultimate goal is just improvement of quality of life. And so I think that that is definitely an important part, but also making it accessible for patients to know that they don't have to follow XYZ. They can only eat organic. All that does is add stress. And as far as I'm concerned, you put that kind of stress on yourself and it can make you just as inflamed and miserable. So it's like, let's just try to keep it chill if possible, make good choices, and try to work with somebody who's going to be nuanced and understand that we're individuals.
Absolutely. And make sure they're working with the rest of your team. I think something patients a lot of times blame themselves. And I brought this up for that reason, because there are a lot of patients. I've rarely worked with a patient who eventually maybe we find out it's endometriosis or has that history, who isn't doing everything within their power to do better, right? They're moving their bodies. They're not drinking alcohol ever. They're sleeping as well as they can. They're eating all the fruits and vegetables, eating quality proteins. They're trying not to eat out as often. Like, I rarely see patients who are not being very serious about it and taking every action they possibly can to make things better. And sometimes the conversation is less about let's make it more perfect and more about actually you're doing everything that you can. We need to start looking outside of this box, because this is not the only piece of it. And like, yeah, there's some changes we can make specific to digestion. There are things out there, but if my answer is just to try to nitpick your diet to where you have nothing left or throw a billion supplements at you, it's probably time to start the conversation with different specialists or have a better conversation with the entire team. Because if you're doing it all right and things aren't improving, like, it's probably not something within your control. That's there. And patients, I think sometimes that's really important to hear, because the downside of online is that it can sometimes feel like, even with the best intentions, I share a lot of information, in the IBS space. And I think even with the best intentions, showing like, oh, you can do all these things and it's possible, you only see every side of it. And it can be easy as a patient to say, well, I guess I need to be more perfect or more strict, or I'm not doing something right. And you start to feel guilty or ashamed that that's the case. And it's not necessarily true. It's not true on the IBS side. Definitely not true when we look at endometriosis, IBD, all of these different conditions that all kind of encapsulate, I guess, our communities.
No,
but
absolutely. Yeah. And it's, I tell people, it's, over time, eating that one cookie is not going to make your endometriosis flare back up. And one of the best things a doctor ever told me was a surgeon. And he's like, ultimately, he's like, part of your well-being, your health, and moving forward is going to be doing what makes you happy and finding that joy. And if having a cookie every once in a while is bringing you that much joy, like, it's like mine is desserts. I am a dessert freak, and I eat my dessert without guilt. But I have seen people who genuinely will say things online like, "Oh, that'll make your endo come back." And that is so harmful, and I hate that for patients, because that's just taking away one little bit of normalcy that they maybe could have. And that it just really breaks my heart. And so I really think it's important. It's one reason I actually really love you. For anyone who doesn't know, I reached out to Erin quite a while ago, just because the content was so good. And I was like, man, she could really help so many of the endometriosis patients that I work with that I'm just on a loss with. And because the information is good, it's nuanced. And I know that your heart is always, in the right place with helping patients. So, and I can tell that. So that was really important to me when I reached out to you. But it is, like you were saying, it's just all about finding the balance. And if someone takes anything away from this right now, it's, if you are doing everything right, like you were saying, and it's just not working, it is time to think outside the box. There are so many other things that things can be, and you're not doing anything wrong. It's just you haven't found what's works for you yet.
Absolutely. And it's worth it to keep trying because it exists. And on that note, it's a great stopping point for us, but I will include the Endo Girls blog in the show notes. So if you're interested in diving into more of that information, it's a great place to start. Even with trying to figure out the provider that you want to go see or whatever, you're trying to decide, and some of the information. I know we didn't get into the new blood test, and then there's all this stuff. So I think some of that, do you cover the new blood test on your website? If you have
the new blood test that comes up every couple of years, yes.
Yeah, exactly. Yeah. I was like, you covered it on socials, I know for sure. But Yeah, that's on there. So a lot of the information that you might want to like dig a little bit deeper into if this was a helpful starter conversation. And then I'll also tag the Instagram account so that if you want to connect to another community that is specifically focused on endometriosis, if you already have it or you're navigating that, that is really helpful. Sometimes communities of patients are not always the most helpful, but I still think that they're more helpful than they are not, as long as you also have a sounding board for the rest of that conversation. But really hearing other patients' experiences and kind of getting that encouragement from other patients is so necessary. So all that's in the show notes for you if you want to check that out. And then Katie, is there anything else I missed? Any other resources that would be
I will
helpful to
send,
include?
actually, if you don't mind, I will send over some of the information that I use for my statistics so that if anybody wants to dig through that, I always have my resources available.
Wonderful. Yeah, we'll include that as well. Well, thank you so much, Katie. I really enjoyed this conversation. I hope it was helpful for those listening, and maybe have you back another time.
Okay.
Yeah, it'd be really fun.
Are you listening to today's episode with the main thought being, what are the steps that I can take to get rid of my symptoms right now? While I hope that the information that we share in every episode of The Gut Show leaves you feeling more empowered and more confident in your body, it's not always going to solve your problem or give you a clear direction for your specific symptoms and your needs. The Master Method membership is an online program for the person with chronic digestive symptoms and IBS who wants step-by-step guidance to understand their body, address the drivers of IBS, reduce symptoms, and build resilience in your gut long-term. This membership includes a step-by-step course and a dietitian-led community that teaches you how to holistically address each symptom and the IBS drivers, how to reduce symptoms more strategically and with confidence, and guidelines for better gut health long-term so that you're not only thinking about today, but you're also improving your outcomes in the future. It is time to ditch the symptoms and get your life back. The membership is your first step. You can learn more and enroll at IBSmastermethod.com and use the code GUTSHOW, GUTSHOW, GUTSHOW for $25 off your enrollment fee.